Welcome to NLXP. My name is Dr. Dean Vafiatas. Today we're going to be talking about provisionalization and long-term implant therapy, ceramic and composite materials. I'm the program director at the full mouth rehabilitation course at NYU and also a clinical professor of the Ashman Implant Department at NYU. This is a presentation that we presented at the AO meeting in 2009, and what we are talking about is the problem. What do we use for fixed long-term provisionals in the anterior and in the posterior regions? Many times implants are placed, grafting materials are done, and the time sequence from the time of the implant or the graft placement till the time of the final restoration could be 6 months, 12 months, up to a year and a half. In that period of time, the patient has to have something that's functioning, that's aesthetic, and that can transfer the loads of the occlusion during the period of time while the implants are healing. The materials commonly used are removable partial dentures with self-curing acrylic or heat-processed acrylic. Sometimes wire-reinforced acrylic provisionals are used, and they have their value, but they also have their limitations, and we'll discuss that. Some of the problems in prior practice we find is the colors of the acrylics are not stable. Anything greater than 6 months sometimes gets decayed or gets dislodged. Usually it's breaking, or some of the teeth become non-vital, they become sensitive. There's a lot of issues that we have with provisionals with acrylic materials. So over the course of the last 5 years, we've been searching for different materials that are a lot easier to work with. And the four that we've discovered be very helpful in the clinical practice was the Vita CAD Temp, which is a cross-linked acrylic polymer with a microfilled block material. The good thing about this, it's made by a computer, it's very accurate. The negatives are that it's only good for 3 or 4 units, so the block is only a certain 30 centimeters long, and then we can't use it for longer span bridges. The Tessera Bisco company has come up with an aquathermal light indirect composite material that's very dense and also has some non-precious metal within it, so that holds provisionals for 6 to 12 months very successfully with beautiful aesthetics and good characteristics of wear. The ceramic metal PFM lab temp we've been using for the last 4 years in different practices, and we're testing it out. It's been very successful. It's basically a ceramic metal provisional for long-term provisionalization of implants and grafted areas, and basically a ceramic metal bridge that holds the vertical dimension, very color stable, and can protect the teeth along the way. In addition to that, we'll use the performance post, which is basically a peak material for any kind of provisional implant restorations while things are healing. The methods that we use is the full contoured wax-up, the putty matrix for making the provisional restoration. So we get a full contoured wax-up, we take a putty matrix of that, and then we use the Luxatemp material, which is from Zenith DMG, or the ProTemp material, which is a composite material. It's very dense and very accurate, has very low shrinkage. We use the matrices to take the provisional to the mouth, and then we cement it with either a bonded cement or a temporary eugenol cement, and it works very well. We use the clear matrix also, or the putty matrix. Both work well. So once we have established the patient treatment that we want, we take a look at a simple case like this where there's a 3-unit bridge going to be prepared. The molar is going to be extracted and grafted. We need at least 4 to 6 months for the grafting, and then we need at least 4 to 6 months for the implant to heal. So that we're talking about a minimum 8 to 12 months for a restoration. So once we prepare the unit, and the implant surgeon, the periodontist, does the grafting material, the provisional is placed and it's cemented with either a Durolon and Vaseline cement or a Temric cement. And you can see the CAD Temp comes in various different colors, and it could be stained and glazed, and we can produce a different color depending on the type of patient that we're treating. And that provisional stays in the mouth for a period of time while the graft is missing. And another patient treatment where this premolar has been extracted 4 months prior. The patient never came back, so he returned after a year's time, in which they developed some caries on the canine, and the molar is starting to get a little weak. But we can see that the position of the implants will be placed in the sinus area, right around there, and a multiple graft procedure in combination with the implants will be placed. So in this type of scenario, we can measure out over a 30-centimeter block, and we can scan it with the CEREC machine. The CEREC machine basically scans the preparations. It scans it on a model or intraorally, and we create that ideal position for that implant, and it's milled out in about a 30-minute period of time. After that, we will reline it with a Luxatemp material using the 2FL from Optibond, and basically cement it in position with a very strong cement like Temrex or Durolon with Vaseline. You can see the aesthetic position, the guidance position on the canine, and the tissue response. So this patient can go on and do the grafting, have a very strong temporary, and we can evaluate that in about 6 months' time. The Tessera material is a little bit more for longer-term provisionals and longer spans. Basically, the old bridges are going to be removed. There's some treatment planning issues. We look at the sinus grafted areas, some failing implants that have to be dealt with. But once we figure out our treatment time and our treatment planning, and we know the patient has to have some grafting material, we'll go ahead and prepare the case, do the provisionalization with our wax up. So the first time the patient walks out with the regular provisionals. Once we take final impressions, those impressions get sent to the laboratory, mounted casts, and the Tessera 4-unit bridges are fabricated. The vertical dimension is measured with a caliper, so we in this particular case, we're going to restore a little bit of the vertical to get more convenience for restorative material. And you see that before a patient is in this treatment and after the preparations with the Tessera material, the patient can walk out in this position. Once this is done, then the laboratory and the periodontist or the implant surgeon or the oral surgeon can take out the provisionals in a very easy way and then start placing the grafting and then start placing the implants. And the patient can have these provisionals up to 12 months. We use the provisional abutment performance post for areas where we need a little bit more support. We'll place the implant in an area where we have some support, make the provisional, and basically scan it, take a look at it, and then usually after the graft is done, use that performance post to be able to hold the provisional over the 12-month period. When we get into longer periods of serial extraction cases or highly aesthetic needs, we use the ceramo metal provisional. This patient treatment, we needed to graft the posterior areas. We needed to extract the 2 lower mandibular incisors. And once they are extracted, we can provisionalize with our regular material, take final impressions of this, and then deliver a ceramo metal lab temp. And you can imagine that we did not do a metal try-in. The margins may not be perfect. They may be within 100 or 50 to 100 micron level, but that's only to hold that provisional for a year's time. So we're looking for something that's strong. We use a semi-precious material, not a non-precious material, because it's a little bit more accurate. But the alternatives with acrylic temps that we've seen over the years is the breaking, the leaking, and everything you see listed here. That will be a very difficult thing for the surgeon when they're removing the temporaries and breaking them and having little problems with the teeth that are supporting the prosthesis. So we don't want to lose the teeth along the way. We preserve them. Over the course of time, the patient gets grafted material, then he gets a second stage of implants, so we're into an 18-month treatment time. All the while the patient is wearing the mandibular ceramo metal long-term provisional PFM ceramo metal temporary. And that's been very valuable for vertical dimension, supporting the tissues, cleanliness, long-term wear of the teeth, no leakage compared to the acrylics, and breaking and all the things that we discussed. So that's been a very valuable treatment. And then afterwards, the patient, once the implants are exposed, you can see the temporary provisional bridge has been sectioned. The implant restorations are completed. Once the implant restorations are completed and they're in position into the vertical dimension that we've chosen, then we can go back, remove the old bridge, take final impressions, and make a final bridge for the anterior. But the posterior work is completed. Another patient treatment that we discovered, again, value of the PFM provisional, is once the aesthetic needs of the patient were discussed, we had to do some surgical processes and go ahead and extract teeth, place implants, do grafting. It was a multiple procedure. The case treatment would have been up to 12 to 15 months. So in this patient treatment, what we will do is prepare the back teeth where we see the sinus grafted areas must be done, and we'll prepare ovate Pontics. We'll use the provisional material Luxatemp to go ahead and initially provisionalize the patient, take final impressions, take final vertical records, and then bring back the PFM provisionals, as you see here, and they are adjusted to the occlusion, make sure the centric position is okay. We will then go ahead and insert the anterior work. You can see on the right slide that little recession has occurred over the grafting. And when we come back 9 months later, the tissues are ready. One of the implants was placed immediately. Now the second phase of implants needs to be done. And you can see this was the first phase of implants. These are the provisional PFM abutments that are taken off 9 months later. we see no leakage in the IRM that we used in this provisional. And then we can section off the pontic, create that PFM provisional, and then place a second round of implants. So again, we're into a 18-month to 24-month period of treatment, all the while the patient is wearing the PFM provisional. In the interim, we did some aesthetic work in the anteriors. Peter Kravaris oral dental design from JK Laboratories, and after the other implants were exposed, the final restorations are in position, and they're all individualized implants and ceramo-metal restorations. This was a patient from one of our doctors, Dr. Mike Appa, who teaches with us, and his patient needed a similar treatment where she was losing a front tooth, number 9, and she opted to do some aesthetic work but really wanted to have implant therapy. And we realized if we extracted that tooth, she'd be in a very difficult position and she could not wear something like a removable partial denture. She wanted something fixed, so we opted to go ahead and start the aesthetic work. We placed a 3-unit provisional. We took final impressions. It was sent to the surgeon. The surgeon did the flap. He did a graft with demineralized bone and a large connective tissue graft. But then what we did is, so that she wouldn't walk around with anything anesthetic, we went ahead and made a PFM lab temp in addition to the veneers and the aesthetic work that she needed. So during the time of healing of her implant and her graft, she had a good smile. She can still go out and do her modeling work. And Dr. Chadroff and Dr. Mike Appa have done some great work with this patient and keeping her together. So to review, we have the Vita CAD temp, the Tessera Bisco temporary, the ceramo-metal PFM lab temp, and our performance post that help with some procedures. So the advantages are listed here. The disadvantages are in red. For the lab temp, limit is up to 4 units. The technology, and it has a learning curve, and you need to be a CEREC owner to do this. And you can see the CAD temp comes in a block size temp. It's milled into position. We can do very nicely 3-unit bridges and 4-unit bridges on the interior, and they're very aesthetic and different colors come in various forms. The Tessera material also for 6 to 12-month periods of time. The disadvantages are investment in the laboratory, a little education in the laboratory, but the materials are very solid and very good in terms of long-term wear of the occlusion, porosity-free, because they're light-cured and they're heat-cured. They have a really low porosity rate. And the colors are really wonderful because you can kind of blend them with the Foster had published a couple of papers, and you can add the wire and the reinforcement. This is one of our patients in the office who needed a lateral, and we basically made that from the Tessera and bonded it into place. So it's been a good provisional for over 6 months. The ceramo-metal, well, the cost is a little greater than regular acrylic, and it has to involve the adjacent teeth if we're doing it. But the benefits of maintaining the vertical dimension, maintaining the color stability, protecting the teeth over the long term of 12 to 24 months is a very valuable type of treatment. It's been working out really well. And in this patient treatment, when the patient walked in with partial dentures, once we removed the dentures, we realized there was a lot of grafting to be done. The patient wanted 100% individual implants and was ready to go for the grafting. And again, we explained to her that this is a minimum of a 24-month situation, and what would she have in the interim. So after taking final impressions, we made her a ceramo-metal bridge, which also showed the surgeons of how much hard tissue was necessary to be grafted. So it was a good learning curve for the surgeons as well to realize the amount of hard tissue that need to be rebuilt. But she stayed with this, cemented with IRM over the course of the 24 months, and as the implants got exposed and as the implants and the grafted got increased, we reduced the porcelain until we got to the point where we wanted. So yes, there's a lot of work in adjusting the porcelain, but I think overall the patient during the course of treatment was much more comfortable, was much more in the light of their quality of life and can function with in their social life. I want to thank the doctors and the surgeon and the technicians that have helped us through this presentation. I thank you for your time, and sometimes you may see me win an Academy Award, but I look like some of these guys. Thank you for your time, and any correspondence can be sent to drdean17@aol.com. Thank you.